Hi, my name is Ben Usani and I'll be doing Unit 4 Case Connections today. Case number 1. A newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. Which diagnostic would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation? The choices are A. Blood glucose, B. Urinary acids, C. Serum fatty acids, and D. Plasma glutamine. A full blood workup was ordered for this female, and the data is presented below. The initial blood ammonia level was elevated at 314 micrograms per deciliter. Normal range is 17 to 80, and rapidly rose to 600 micrograms per deciliter. The urine uric acid level was markedly elevated at 473 micromoles per liter creatine, and the normal level is 0 to 3. The plasma citrulline level was normal at 10, and the normal level is from 12 to 55. In this patient where uric acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. So first I'd like to discuss the diagnostics, and it's going to be plasma glutamine versus other diagnostic tools. I think it's plasma glutamine because it's a non-essential amino acid and it's non-toxic to the body. And in urea cycle disorders, plasma glutamine levels tend to be high and are and as well as ammonia. And as you can see, like she has high ammonia levels, and this would work better. Whereas in beta oxidation disorders, glutamine levels tend to be in a normal range. But for blood glucose, it's more useful in finding beta oxidation disorders. Again, for blood glucose, it's usually normal within urea cycle disorders. Urinary acids are used more for urea cycle disorders, but is a more complex test. And serum fatty acids are more useful in finding beta oxidation disorders. The patient has ornithine transcarbamylase OTC deficiency. OTC deficiency is a rare X-linked genetic disorder characterized by complete or partial lack of the enzyme ornithine transcarbamylase, or OTC. This deficiency is generally found in males, and the ratio is normally 85% to 15%. Now, the signs and symptoms include hyperammonia, lethargic, low body temperature, refusal to eat, vomiting, hepatomegaly, and hypotonia. And the patient has several of these symptoms, such as hyperammonia, and she's also lethargic. The enzymes that are least impaired and most efficient in the urea cycle. And as you can see in this diagram, you see that you see the cycle, and we know that she has OTC deficiency. So then all these are going to be essentially lower, but this would be the most decreased or deficient enzyme. And the least impaired would be CPS1. This is because there's nothing affecting it from this half of the cycle. It's only when OTC comes in, there's no way to get carbamylase phosphate to citrulline. So the only difference, this would be the least impaired, and this would be the most deficient. Next is case number 2. A 4-day-old infant, patient A, is being followed in your clinic. Her birth weight is 5.9 pounds, and the pregnancy and birth vaginal delivery were normal. Results from newborn screening demonstrate a phenylalanine level of 6.6 milligrams per deciliter, and the normal range is 1 to 2. A presumptive diagnosis of phenylketonuria was made, and additional samples were obtained for further analysis. The parents deny a family history of PKU. As a consequence of this presentation, which amino acid may become essential? Phenylalanine dietary restriction therapy was initiated at 14 days of age, and with good response of plasma phenylalanine levels that dropped to within the normal range, which is 1.65 milligrams per deciliter. What are the potential causes of the presentation of phenylketonuria? Another infant Patient B is also evaluated for a suspected PKU. BH4 loading tests are performed on both patients and results are presented below. The diagram I will show later. The way the BH4 loading test is made is tablets of synthetic cofactors are dissolved in 20 milliliters of water in dim light and administered to the patient at least 30 minutes before a meal. Blood was drawn before and 4 and 8 hours after BH4 loading. Phenylalanine levels are determined. How would you summarize the results of this test for patient A and patient B? So first I'd like to talk about what PKU is, or phenylketonuria. The definition is an inherited disorder that increases the levels of phenylalanine in the blood due to mutation in the PHA gene. The PHA gene helps make the enzyme phenylalanine hydroxylase, which converts phenylalanine to tyrosine. Signs and symptoms can include permanent intellectual disability, seizures, delayed development, behavior problems, psychiatric disorders. Some may have a musty odor due to excess phenylalanine, and they may have low birth weight. And the last bullet point pertains to mothers who have a high phenylalanine diet while they're pregnant, and patients may have a low birth weight, slow growth, heart defects or problems, or microcephaly. And generally for this patient, she doesn't have any other symptoms or signs other than that she has high phenylalanine levels, and she does have a slight low birth weight. So an essential amino acid for PKU. This would be tyrosine. This is because due to the inability to hydroxylate phenylalanine, tyrosine becomes an essential amino acid. And if you have decreased tyrosine, there's decrease in other acids, amino acids, such as melanin, as you can see here. Now, this is the diagram for BH4 administration between patient 1 and patient 2. As you can see, patient A has a slight increase in phenylalanine levels after 8 hours. So this is before they administered, 4 hours, and 8 hours later. So patient A has a slight increase, and patient B has a significant decrease in phenylalanine levels. And in some cases of PKU, patients are treated with dietary restriction with less phenylalanine, but others may be missing the cofactor BH4, so they might not be missing essentially phenylalanine hydroxylase, which hydroxylates phenylalanine to tyrosine. They're just missing the cofactor there, which is BH4. So in the previous slide, we showed again the patient has a slight increase in phenylalanine. Patient 2 has phenylalanine levels drop significantly. So patient 2 has a BH4 deficiency, not PKU. This is because once they gave BH4, then you see the initial drop of the patient's phenylalanine levels for patient 2. Whereas patient 1, when they administered BH4, there was no change, and instead there was actually a slight increase because phenylalanine levels tend to increase. So, and that's all for today. Thank you.